Prevention's Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions, to promote the use of the best available methods, and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the Q&A pod. You'll need to open the pod by hovering your cursor at the top of the Teams window and then clicking on the Q&A icon. We will open the floor to questions at the end of the presentation. The video recording will be posted on our website, prevention.nih.gov/mindthegap, in a few weeks. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Dr. Moyer. I'm very pleased to say that today's speaker is Dr. Denise Esserman. She is a professor of biostatistics at the Yale School of Public Health, the co-director of the Yale Center for Analytic Sciences, and the director of the Biostatistics Core for the Yale Program on Aging. Her work, both collaborative and methodological, primarily focuses on the design, coordination, conduct, and analysis of pragmatic clinical trials, including cluster randomized trials with time-to-event data and competing risks. She also works with patient preference trials, step wedge designs, and individually randomized group treatment trials. She was a senior statistician on the STRIDE trial and will be speaking about that project today. I'm really looking forward to this presentation because time-to-event outcomes are important in cluster randomized trials. And the methodological development there has not moved as rapidly as developments have in some other areas. So we're going to learn about what we can do with time-to-event data today. It's my pleasure to welcome Dr. Denise Esserman.
Thank you. So welcome, everybody. As was mentioned, I'm going to be talking about the design and analytic considerations for time-to-event outcomes in cluster randomized clinical trials. Here's just my disclosures. In 2021, Kaye et al. Published a methodological review. The objective of their review was to estimate the prevalence of time-to-event outcomes in cluster randomized trials and examine the statistical management of these outcomes. Briefly, they searched 6 major medical journals: Annals of Internal Medicine, JAMA, New England Journal, PLOS Medicine, BMJ, and The Lancet, for cluster randomized trials, and extracted information on the nature of the outcomes, the statistical methods used for sample size, analysis, and measure of intercluster correlation. They came to the following conclusions. Time-to-event outcomes are not uncommon. 17% of the 184 cluster randomized trials had a time-to-event outcome as the primary or secondary outcome or in a sensitivity analysis. Appropriate methods were infrequently used for sample size and analysis and estimation of clustering, and a number of the studies could have analyzed at least one outcome more appropriately as a time-to-event outcome, but did not. 5 years later, most of their conclusions still hold true. There are still gaps in available statistical methods, and more guidance on planning and analyzing cluster randomized trials with time-to-event outcomes is needed. So for this talk, I'll be framing some of the issues in cluster randomized trials with time-to-event using the STRIDE trial. I will discuss some of the design considerations and the methods available when designing a cluster randomized trial with a time-to-event outcome. I will also talk about some of the challenges in analyzing these complex data. I will touch briefly on considerations when trying to monitor a trial when the primary outcome is a time-to-event outcome. I will wrap up with a discussion of gaps that still exist and some potential future work that could be done to address these gaps. This talk will remain high-level and pragmatic, focusing more on methods that are currently available to be used in practice and where gaps may still exist. And therefore, I will not be presenting statistical equations, with the exception of 2. As stated on this slide, this will not be an exhaustive review of all methods. There is a large bibliography at the end of these slides, which we'll figure out how to make available, but I know that it does not come close to covering all available literature and methods. So I wanted to start by introducing the STRIDE trial. A lot of the work our group has done in clustered survival data has been motivated by this trial. STRIDE was designed in 2013-2014. It was a pragmatic cluster randomized trial. 10 U.S. healthcare systems contributed 86 clinical practices. Randomization was at the practice level using covariate constrained randomization, stratified by healthcare system, and patients were mainly recruited from the practice using centralized screening. It tested a multifactorial, individually tailored falls prevention strategy that was delivered by a falls nurse care manager. And the trial was funded by NIA and PCORI. This was a large pragmatic study with limited inclusion-exclusion criteria. Participants were eligible if they endorsed one of the screening questions indicating an increased risk of fall, were at least 70 plus, and were able to provide consent or proxy assent. I've highlighted age here because this was a criteria that ended up being modified to help with recruitment. The primary outcome was a time to first adjudicated serious falls injury. Data on falls were collected every 4 months through telephone interviews, and the assessors were blinded to treatment assignment. All self-reported serious fall injuries were reviewed by an adjudication committee and were verified using the electronic health record and/or Medicare data as source or through medical records when necessary, as recurrent events were used in supportive analyses. Secondary outcomes assessed in a time to event analysis were first participant reported fall injury and all falls, and serious adverse events were hospitalizations and death. A total of 86 primary care practices were randomized, 43 to the falls care intervention and 43 to enhanced usual care or control. They just received a pamphlet, was their enhancement. Final enrollment was 5,451 participants, with 2,802 in the intervention arm and 2,649 in the control arm. All participants were included in the analysis. A total of 296 participants died before having a fall outcome, which was approximately 5.4%, and 376 withdrew consent, which was approximately 6.9%. Of the potential observable follow-up time, 86% was observed in the intervention arm and 88% in the control arm. So for the primary outcome of first adjudicated fall injury, what was observed at the end of the trial was 4.9 events per 100 years of follow-up in the intervention group and 5.3 events per 100 year of follow-up in the control group. One of the main issues that we needed to deal with in the STRIDE study, because the patient population who were older adults at risk of falling, was we had to deal with censoring due to death. In STRIDE, we had a non-terminal outcome, which was falls, competing with a terminal outcome, which was death. This is usually termed a semi-competing relationship, where the non-terminal event, like repeated falling, is influenced by the terminal event, death, creating a dependent relationship, where the terminal event stops the non-terminal event from being further observed and truncates the follow-up time, but where the non-terminal event does not do the reverse. Competing events, on the other hand, are mutually exclusive outcomes where one event prevents the other from occurring, so death from different causes. For the primary outcome in STRIDE, since we were interested in the time to first event and not subsequent falls, death and first fall were considered competing events. Now that I've framed the STRIDE study, let's discuss some of the analysis considerations in the clustered survival space. So first, let's discuss the level of complexity of potential data that we could see. To orient you, we are plotting data from 10 individuals nested within 4 clusters. The cluster membership is indicated by color. The ID of the individual is on the y-axis and time is on the x-axis. Administrative censoring occurs at time 300. In the plots on the left-hand side, an open circle indicates for any, let's say, non-fall event, such as loss to follow-up, dropout, administrative censoring, or death. And on the right-hand side, censoring due to death is indicated with a circle with an X through it. In the upper left panel, individuals are clustered within practices, but censoring due to death is considered independent and treated the same as loss to follow-up. This may occur when death is not something of concern, like events in a pediatric population, such as time to first asthma exacerbation. In the upper right panel, individuals are clustered within practices, but censoring due to death is not treated independently. So this is similar to what we had in the STRIDE study. In the lower left panel, individuals can experience recurrent events and are clustered within practice, but death is considered independent censoring. And in the lower right panel, individuals can experience recurrent events and are clustered within practice, and death is not treated as independent censoring. And this is similar to the STRIDE supportive analysis. It's important that we understand when doing any of these types of trials or analyses the complexity of our data, because clustering can have an impact on our inference. If necessary, we may need to account for multiple levels of clustering, such as within individual correlation, which is the dependence between two event times of different causes, and between individual correlation, which is the dependence between event times of the same cause for different individuals. There are two broad approaches to modeling clustered survival data: frailty models and marginal models. I'll go into more detail, a little more detail on each of these, and then briefly discuss how to decide which class to use. But in general, frailty models fall into the mixed model space, where we account for clustering through a random effect called the frailty. We're looking to answer subject-specific type questions, like for a specific cluster, what did the treatment do? With marginal models, we're in the generalized estimating framework space, where we're answering questions on the population average level. On average, the treatment did what in the population? While the focus of this talk is not on Bayesian methods, I do not want to exclude them as a powerful framework for analyzing this complex data, and I'll mention them briefly towards the end. So just a little more on frailty models. A frailty model is a survival model with at least one random effect, also known as a subject-specific random effects model. A frailty is a latent random term and is used to measure unobserved heterogeneity. The unobserved heterogeneity is included as a multiplicative random effect, and individuals with higher frailties are considered more frail. The variance of the frailty term is an indication of the amount of unobserved heterogeneity. Shared frailty models are models in which individuals in a cluster share the same frailty. So for example, in the STRIDE trial, where individuals are clustered within a practice, we could model the correlation of individuals within the practice using a shared frailty. A shared frailty model could also be used to model the correlation amongst recurrent events. Common distributions have been used to model the frailty, such as the gamma distribution. And Balin and Putter have a nice tutorial on frailty models, and there are several textbooks available that go into detail on this. More complicated frailty models can address the increased complexity of clustered survival data. Nested frailty models can be used to model the hierarchical nature of clustering. For example, recurrent falls for an individual where individuals are nested within clinical practice. And joint frailty models are available to help link two survival processes, a recurrent event process and a terminal event. Frailties can be shared across these processes to account for the dependence. This allows for studying the joint evolution of the two processes over time and the relationship between them. For example, those with more recurrent events may be more likely to die. A lesser known method for accounting for correlated survival time is the additive survival model. This model is an alternative to the Cox proportional hazards model and is constructed by adding the random effects terms directly to the baseline instead of multiplying them. The association is not a hazard ratio, but a risk difference. The advantage of these methods is that they allow more flexibility, as they do not make an assumption of proportional hazards. This makes it easier to address time-varying covariates, including potentially considering a treatment effect that may vary with time. One of the major issues with cluster randomized trials, which I will touch on a little more later, is the small number of clusters, which is the sample size of the trial. Therefore, it is important that any methods that are used address the impact on inference of small sample sizes because they can often introduce bias if not properly corrected for. We developed an additive mixed effects model, which included a frailty term to explicitly account for the dependency between the failure times. And we improved inference for the treatment effect parameter via the development of bias-corrected sandwich variance estimators and quasi-score randomization tests. Listed here are a few of the available packages and what they're capable of doing. Without going into too much detail, there are various estimation methods that can be used for fitting frailty models, including penalized likelihood methods and the EM algorithm. These packages use different methods and have different key features. It is important to look into the details of the packages when deciding on which will be ideal for answering your research question. Frailty Pack allows for diverse and complex model structures and can handle a broad range of models and complexities. For example, you can estimate joint models of recurrent events in a terminal event. It also has functions that can help with power and sample size calculations for shared, nested, and joint frailty models using 4 gamma-based designs. The PAR-FM package fits parametric models and is good when the baseline hazard is known or could be assumed. The survival package allows for gamma and log normal frailties. And for more straightforward log normal shared frailty models, Cox-ME is a well-known alternative. I would be remiss if I didn't mention that there's also support for frailty models in SAS and in Stata, and I'm sure other software packages as well. Transitioning to the second broad class of models, marginal models. These are models that adjust for clustering via a robust sandwich variance estimation. They model the marginal distribution of a response variable, treating the correlation as a nuisance parameter. These models provide valid inference with robust standard errors, even if the correlation is not correctly specified, as long as the model is correctly specified. We were motivated by Stride to carry out a simulation to compare the operating characteristics of several population average survival models that account for clustering. We considered the marginal Cox that censors the competing event of death and 2 methods that account for clustering in the competing event, the fine and gray model and the multi-state model. The fine and gray model accounts for competing risks by directly modeling the cumulative incidence function. This is called the subdistribution function. The multi-state model is an alternative approach that addresses the competing risks by formulating different transition intensities or hazards to model transitions between different states. So for example, between falls and death. The models that do not account for clustering were used, as will be shown on the next slide, to estimate the inflation of the variance when adjusting for the intercluster correlation through the sandwich variance. As I mentioned, we conducted a simulation study to evaluate the operating characteristics of the 3 types of methods. The data were generated under a model that included clustered survival times and a competing event. We considered a 2-arm cluster randomized trial with equal randomization. We considered varying numbers of clusters, 100, 30, and 10, and varied the cluster sizes. We generated correlated survival times varying the level of within subject and between subject correlations. We fixed the baseline hazard and dropout rates, but varied the hazard rate for death and varied the between and within correlations. So there was a lot of parameters to consider in these scenarios. What is presented here are the results from estimating the variance inflation factor for the situation when there are 100 clusters and where we varied the competing event rate from 0.2 to 0.12 and fixed the within correlation and varied the between correlation. The variance inflation factor is the ratio of the cluster robust variance and the variance ignoring the clustering for each of the 3 model types. A closed form variance inflation factor is intractable with complex survival outcomes, presenting a major challenge for designing cluster randomized trials in our setting. The results in this table provide some intuition on the magnitude of the variance inflation. And as can be seen, increasing the between correlation can have a pronounced effect on the variance inflation factor. Our findings imply that the variance inflation factor in cluster randomized trials with complex survival outcomes is driven by both within individual and between individual correlations, as well as the competing event rate, and it occurs in a nonlinear fashion. And given the sparsity of published information on the correlation in complex survival data, it is unclear what we can expect to observe in terms of the size of these correlations. As mentioned previously, the sample size in a cluster randomized trial is the number of clusters and not the number of individuals nested within the clusters. Most cluster randomized trials do not enroll large sample sizes, with approximately 50% having less than 30 clusters. The 86 practices enrolled in STRIDE was not the norm. In our simulation study, we found that with no more than 30 clusters, the sandwich variance can exhibit notable negative bias and inflated type 1 error rates. Given that most cluster randomized trials enroll small sample sizes, it's important that small sample corrections are considered for valid statistical inference when employing marginal Cox models. We found that a permutation test will provide better control of the type 1 error when the sample size is small. Wang and colleagues proposed 9 different bias corrections for the sandwich variance under the marginal Cox model. They found that optimal choice of bias correction is dependent on the variability of cluster sizes and the metric used to evaluate the methods, whether you want to consider relative bias or type 1 error. They provide an R package to implement the proposed corrections to the sandwich variance estimators. The take-home message is that when the small sample size is not corrected for, the variance could lead to when the small sample size is not we're not correcting the variance for the small sample size, we could lead to substantially inflated type 1 error rates, sometimes even larger than 20%. It's important to understand as well the difference between estimates produced by the fine and gray method and through the marginal Cox model. The fine and gray method estimates the subdistribution hazard, and the marginal Cox model estimates the cause-specific hazard. The difference between these two methods mainly lies in who is in the risk set. For the cause-specific hazard, the focus is on the event of interest while removing from the risk any other causes. Thus, if a participant experiences the competing event, they are removed from the risk set because they no longer experience the event of interest. While for the subdistribution hazard, those experiencing the competing event remain in the risk set. This directly corresponds to a cumulative incidence function and translates to a measure of risk for the event of interest. It is important not to interpret them the same. As an aside, when we conducted our simulation study, in order to estimate the relative bias and coverage probabilities, which I didn't show, but are presented in the paper, since we could not expect the treatment effect to be the same for the marginal Cox models and the fine and gray models under our alternative hypothesis, we numerically approximated the true values of the parameters through additional Monte Carlo simulations. I share this because it is important when comparing these methods that we do so appropriately. Just to circle back to frailty models versus marginal models, the key difference between the models is the focus. The focus of the marginal model is a population average effect, while a frailty model is more focused on a cluster or individual level effect. In the frailty model, we model the correlation through a random effect, whereas in the marginal model, we treat the correlation as a nuisance parameter and account for it through the sandwich variance. Marginal models tend to be more robust because we don't need to make as many assumptions, whereas the frailty model is less robust because we are relying on being able to correctly define the frailty distribution. When interested in the population average treatment effect in a clinical trial, we would want to choose the marginal models. Coming back to the STRIDE study, the analysis followed the intention to treat principle, but the primary outcome was evaluated using a multi-state model that incorporated the competing risk and clustering through a sandwich variance. The model was adjusted for randomization of the practices by healthcare system and included covariates used for the covariate constrained randomization. Data for participants who were lost to follow-up and had not had a serious fall event were censored at the time of the participant's last interview. And although not used, the statistical analysis plan had use of the fine and gray model for clustered data as a contingency plan. The table on the screen does not provide the results that were published in the New England Journal of Medicine article for the STRIDE trial. Those are slightly different. In STRIDE, the hazard ratio was 0.92 with a 95% confidence interval from 0.8 to 1.6, so similar to what's on the screen. But I thought it might be nice to present these findings from our simulation paper so that you could see what happened across the different methods. They're slightly different because we did not adjust in the simulation paper for the covariates included in the constrained randomization. Although the intervention effect parameters in the Cox, multi-state Cox, and fine and gray models have different interpretation, the estimated intervention coefficients in the STRIDE examples are similar across these three types of models because there was a low event rate and competing event rate. But the three survival models can produce different results and again should not be interpreted as the same. What it's telling here in this slide is that the standard error estimates are the same out to 3 decimal places across all models, whether we adjusted for clustering or did not. What we observed in STRIDE was that there was no variance inflation, thus no correlation amongst participants in the same practice. In our additive paper, we did not analyze the primary outcome, but looked at the secondary outcome of first patient reported falls. Compared to the event rate for the primary outcome, so if you recall back, it was slightly above and slightly below 5 events per 100 person years in the 2 groups, the rate of the first participant reported fall was more than 5 times higher. So there were 25.6 events per 100 years of follow-up in the intervention group and 28.6 events per 100 year of follow-up in the control group. Instead of estimating a hazard ratio, we estimate the risk difference and conclude that the intervention was able to prevent, on average, 30 patient-reported falls in 1,000 patients over the duration of the trial. So when dealing with recurrent events, which was our supportive analysis in STRIDE, we need to consider the complexity of the data. If the only correlation is within individual, so if you were only concerned about repeated events, then you can use marginal methods described previously. However, in a cluster randomized trial, we are more likely going to be dealing with situations where we have correlation within an individual due to repeated events, and those individuals will be nested within a cluster like a practice or site. In this case, we will need hierarchical models that can account for multiple levels of clustering. And then, if we also need to be concerned about a semi-competing risk, then we will need hierarchical models that can account for dependent censoring. Just of note, sometimes Poisson models are used to model recurrent events. However, the focus of these models tends to be the number of events and not the time to the event. So at the time we were designing the STRIDE study, the investigators were considering recurrent falls as the primary outcome. However, we were unaware of methods that could handle the 2 levels of clustering as well as the semi-competing event of death, and we were definitely not aware of any methods for estimating the sample size under these conditions. Therefore, the recurrent events data became a supportive analysis as opposed to the primary analysis, and we had a student set out on solving the modeling issue. He developed a semi-parametric joint model where he joined 2 semi-parametric frailty models, one for the recurrent events process and the other for the semi-competing risk process through 2 levels of clustering, as are seen in this picture. The model estimated variable at the participant level and at the cluster level, as well as took into account the association between the 2 survival processes. One of the limitations identified during simulation studies was that the Jung joint model had convergence issues when the number of level 2 clusters is small and the semi-competing risk rate is low. Luckily, we had a contingency plan in place for the STRIDE study because the Jung joint model failed to converge. The recurrence of adjudicated fall-related injuries was low, and so was the rate of death. Therefore, we defaulted to a practice-level Poisson model. Even though I've hinted at some of the issues with the design of cluster randomized trial with a time to event outcome, let's pivot to talking a little bit more about those considerations. Here's how the sample size was estimated in the STRIDE trial. Using past software and basing the sample size on a log rank test in the presence of competing risk, we assumed an 18-month recruitment with uniform accrual with a 36-month trial duration, a two-sided type 1 error rate of 5% and 90% power with one-to-one randomization of the clusters. The annual rate of falls in the control group was estimated to be 14%, and what we actually observed was much lower. We assumed a 7% annual death rate, which was actually also lower, and 3% lost to follow-up. We inflated by 3% for an interim look, which we ended up not doing, and expected to see a 20% reduction in the hazard for the intervention relative to control. Since sample size for time to event outcome is event-driven, we needed to observe 845 events. From this, we figured out how many individuals needed to be enrolled and then adjusted for clustering. At the time, we did not know the best way to account for the correlation, nor did we know the best way to estimate what the correlation might be. We used the sample size inflation formula for cluster randomized trials, where we estimated the design effect as a function of the intercluster correlation and the size of the cluster. The issue was in the estimation of the ICC, especially since we expected a fair amount of censoring. Of note, there is no methodological basis for this design effect formula in the time to event setting, and it is unclear how the ICC is defined in these situations. We used an estimate of the ICC from the LIFE study, which was estimated from a Poisson model, and that was the best that was available at the time. We assumed 70 individuals per cluster and landed on a total sample size of 6,000 individuals. In designing the STRIDE study, we identified this gap in the literature. We found that the ICC is not clearly defined for time to event outcomes, and there's a lack of reporting, probably because people don't know what to report. Censoring throws a wrench into things. One proposed method is to estimate based on the censoring indicator, while others propose using the observed event times. Kalia et al. Performed a simulation study to explore the effects of administrative censoring on estimating the ICC. And what they found was that the use of censoring indicators or event times led to negatively biased estimation of an ICC parameter. They could not recommend either method and proposed the need for further methodological research. One potential alternative is to explore the variance inflation factor. But as I've stated, there's no closed form formula, and it is driven by many factors and is nonlinear. Kalia et al. Also recommended future research explore potentially the use of Kendall's tau. Kendall's tau is rank-based and can possibly be argued that it may be more suitable to measure dependence in clustered survival times because correlations are nonlinear. Meng et al. Through simulation demonstrated that the magnitude of Kendall's tau is smaller than the ICC, which has no closed form, but was numerically estimated. And you can see the relationship is nonlinear. Of note, reporting Kendall's tau is not common practice, but neither is any form of the estimate of correlation. And this is an area that still needs to be addressed. As stated in the beginning, this is not an exhaustive discussion of all available methods. Here, I just wanted to mention that there are sample size methods that are available based on the Cox model. There are also, as I mentioned for STRIDE, methods based on log rank statistics. Each of the methods presented addresses some of the concerns raised, but also have limitations in regards to the complexities we can encounter. And it is important to recognize that any methods reliant on Cox can ultimately be underpowered if the proportional hazards assumption is violated. The potential biases with using small sample sizes need to be considered in the design of the study. I cannot tell you how many times investigators will come trying to design studies with 4, 6, maybe if you're lucky, 8 clusters. It is a challenge, but it is recommended that at least 10 clusters be randomized, especially if the size of those clusters is going to be variable. We often have large and small clinical practices that we're trying to include. Based on the work of Wong and colleagues, it is recommended that if the cluster size is highly variable, we need more than 10 clusters, because if we do not have enough clusters, then even with bias correction, we cannot guarantee a valid test, which leads to the issue of the variability of cluster sizes. In general, a higher coefficient of variation, a measure of the variability of the size of the practices, increases the required sample size and impacts statistical power. The primary assumption, especially in early sample size formulas, tended to be to assume equal number of participants per cluster and to not factor in variability in the cluster size. We were at fault of doing this in STRIDE, where we assumed a practice size of 70. Rarely do we ever have the same number of subjects per cluster, but identifying what we expect the variability to be can also be a challenge. Here is an example of a way to account for the variability in cluster size and the estimate of the sample size inflation. In STRIDE, we had a mean practice size of 64 with a coefficient of variation of practice size of 0.5. If we had assumed instead that the average cluster size was 70 instead of the fixed cluster size of 70, our design effect would have needed to be 0.66 instead of 0.53, which would have required a 13% additional increase in sample size. Just an FYI, when extending the additive hazard mix models work, we did develop a sample size estimation. It does require an estimate of correlation and understanding the effect size on a different scale than most are used to, but it does allow for unequal cluster sizes. And just in terms of understanding the scale, if we were to redesign STRIDE looking for an effect size of 0.1 risk difference, then we would be looking to demonstrate that the intervention is able to prevent, on average, 100 patient-reported fall injuries per 1,000 patient years of follow-up over the duration of the study. Coming back to STRIDE, we had a slower than anticipated recruitment during the first 6 months. So in addition to dropping the age criteria, as I mentioned earlier, we made some trial adaptations, including extending recruitment and extending follow-up. All other assumptions remained the same, and we came to a final sample size of 5,451. I highlight all other assumptions remain the same, because the DSMB had concerns that the clustering in the practice would have an impact on power, especially with us potentially not meeting our proposed sample size. This correlation is a nuisance parameter, but we had no way of measuring it and what impact it might have. The figure, which is no longer confidential, presents what we did, which was estimate the variance inflation. The black line is the variance inflation, while the blue and red lines are the standard errors from the model with and without clustering. As you can see, it was highly variable in the beginning when there was not a lot of information to help estimate it, but then it started to converge towards 1. I also mentioned earlier that we had included an inflation to sample size for an interim look. This did not happen. First, this was a low-risk study, so it was okay that it didn't happen. But also, there were no methods that we were aware of that we could use to determine the information fraction, to know where we were in the trial and when we would have enough information to look. We knew we needed 845 full events, but we did not know how many events that translated to when you factored in the clustering. Variance inflation could be a way to make sure that the sample size was improperly inflated to account for the design effect, but monitoring that may not be straightforward. As you saw in the prior figure, it takes time to have confidence in the estimate. And as we can see from this table, small amounts of correlation can already start to have substantial impact on the variance inflation. I've listed here a few examples of work that have been done in the Bayesian space. As I mentioned earlier, I didn't want to forget this area, that touch on some of the issues that we raised with the STRIDE trial, like the need for joint models to better handle both the recurrent event and death processes. Bayesian methods offer an alternative to the frequentist approach and can often overcome some of the convergence issues that are encountered in the complex hierarchical frequentist models. As I mentioned, we had convergence issues with our with our model. However, oftentimes the design elements like sample size estimation are less developed in this space. We did identify many issues and gaps when designing and analyzing data from the STRIDE trial. We have attempted and continue to do so to address these issues. We've had varying degrees of success. However, there are still many unanswered questions. We still need to be able to define and estimate the ICC for complex survival data. This includes better ways to monitor trials and make decisions about trial extensions. We also need to continue to advance methods for hierarchical data with semi-competing event. One potential avenue is to pursue further extensions to the additive model. At present, we're pursuing extensions to the multi-state models. And we can always use more user-friendly tools for estimating sample size. There's a great shiny app for the design of cluster randomized trial by Carla Hemming and colleagues, but it does not include time to event outcomes. Clustered data is complex, but add in censoring and you add in another level of complexity when dealing with clustered survival data. I hope that I've given you some things to think about when designing and analyzing cluster randomized trials with time to event outcomes, but there is definitely more work to be done in this space. And I didn't even dive into the topics listed here that may also need consideration. More often than we think, we are probably encountering interval censored data. This occurs when the exact time to event is unknown, but we know that it has occurred between an interval, like time to dementia, or in some instances, progression-free survival. We only know that the event occurred between 2 points in time, but not the exact time. Methods for non-proportional hazards when we have to deal with clustering and dependent censoring are also a potential issue. I mentioned briefly that the additive model is a potential alternative, but have not addressed other potential methods or gaps in this field. And as was mentioned with the joint frailty model that was developed, there can be issues with convergence and when developing a statistical analysis plan. It is important to understand that decisions should be put in place to help with simplifying the model. In STRIDE, we proposed a Poisson model, but this is an area that needs more discussion and where Bayesian models may be more helpful, but having to specify them in the statistical analysis plan in advance can be challenging. And most of what was mentioned was for parallel group designs. I did not discuss more complex designs like the stepped wedge or individually randomized group treatment trials where there's mixed membership, such as individuals seeing different therapists in a CBT intervention or where group membership may change over the course of treatment. These designs can introduce the need to account for additional correlations, which could lead to more complicated models. I want to acknowledge that a lot of the work that I presented from our group wouldn't be possible without contributions from key collaborators and trainees, and without the STRIDE study to provide the motivating examples for this work. So now I'll open up for questions.
Thank you, Dr. Esserman. Thanks very much. That was a lot of material interesting to hear all the challenges that remain for time to event outcomes in group or cluster randomized trials. You could have given an even longer talk, I think, just focused on the things that we still need to understand. A challenging area. So a question from a colleague here at NIH. For your primary analysis of STRIDE, did you consider using a composite event Cox model of the time to first of either a fall or death? And
no.
Let me ask, did you consider that?
No, we did not, but that's an interesting thought.
Okay. And a second question from the same colleague, what is the multi-state Cox model doing?
What is it? So I don't know if maybe sorry, without making everybody on the screen sick, sorry. So the multi-state Cox model here is modeling for our situation, it's a cause-specific hazard situation where you're modeling the transition hazard or probability from going from the healthy state, from the randomization state to first serious fall injury. And simultaneously, you can be modeling what the death process is here. You can also get out, but we didn't model that. You can get the conditional hazard of after having experienced a first injury, conditional on that, what is the probability of transitioning to death as well. So that's what it's modeling. And it uses, in our situation, what we used is a marginal Cox model to account for the clustering to model those transition hazards.
Question from a different listener. How do intercluster correlation and varying cluster sizes affect sample size and power calculations for time to event outcomes? And what common mistakes should researchers avoid at the design stage?
Yeah, so some of that is still unknown in terms of the best way to estimate what the correlation is. But what we know from cluster randomized trials in general is that the higher the intercluster correlation, the larger the sample size you're going to need to account for the increase in variability. And that the more variable your cluster sizes are, the larger the sample size you'll need to account for the variability of information that's contributed from the varying clusters. How to handle, as I mentioned, this is still how to best handle that is still an unknown. There are different methods that are proposed out there, but they don't quite address everything. And what we had to deal with in Stride is once you get to the recurrent events, then you're dealing with multiple levels of clustering on top of the relationship between the two processes.
Very complicated.
Yes.
Yes. Another question from our audience. When the exact timing of events is not crucial, is there a role for discrete time survival analysis in complex cluster randomized trials?
That's a great question. I haven't thought about that, but I would say there probably is. I think it's related to the research question and coming up with the best model to be able to answer the research question given the complexity of the data that we have.
The Stride trial, I don't remember the exact slide number, but you showed results from a number of different models, including one that didn't account for clustering.
Yes.
Yeah,
this
that
one?
was it.
Yes.
Yeah, that one. And one of the lessons that you pointed out from this slide was the standard error column, where the standard errors were essentially the same across all of these models. And your interpretation was clustering wasn't really substantial in Stride, and if there was an ICC, we might say, well, it was not very large,
right,
in this context. But clearly the standard errors were the same, so the variance inflation factors would have been very close to 1. So in this instance, not much impact of clustering. This is a hard question perhaps to answer, but under what circumstances might we expect more of an effect of clustering? Was it the nature of the outcome? Was it the nature of the intervention? Was it, we wouldn't want to walk away from this slide and think, oh, well, we could ignore clustering when we have time to event outcomes, because it didn't matter.
Yeah. So I think Stride, and actually, if you look at this slide, the crazy thing is, I know it's the 4th decimal place, but the adjusted standard, the marginal standard errors are actually slightly smaller for the first 2 models. and just slightly bigger for the multi-site model, which is what we did. So that's even a little bit really a rare situation. And I think STRIDE was actually a rare case where the intervention was individually tailored. So even though the randomization happened at the cluster level and there was a falls care manager assigned to the practice who was delivering the intervention was actually individually tailored. And then the participants had to actually do the intervention, and whether they did or didn't, we didn't do a good job in the STRIDE trial of tracking and measuring that. And so I think that in hindsight, I'm not surprised there wasn't really a large correlation here, because I think that the participants were actually fairly independent, even though we cluster randomized. But I do think there are places where you're going to see things that are highly related to each other on some of these time to event outcomes, especially like in familial studies where, or the old example of the eyes studies where we could be studying two eyes from the same individual and looking the time to some sort of event happening. Correlation is going to be hugely impactful in those scenarios.
I would agree. We have a question from another member of our audience. In cluster randomized trials with staggered rollout or variable follow-up across clusters, what are the best practices for handling informative censoring and delayed entry in time to event analyses? You said that you hadn't looked at things like step wedge, and I don't know if you have an answer for this question, but we have the question in front of us, so let me pose it to you.
So we have. So I don't want to. I didn't discuss the stepped wedge, but we've done a little work in this book. Me personally, I know others have done more work, a little in this space. Where we looked at step wedge trials with time to event under a cross-sectional setting, as opposed to a more complicated closed or open cohort setting. I think that, yes, it can be complicated. I would think that the design, so if you're talking about like specifically a stepped wedge, that creates some complications, especially if you're thinking about closed or open cohorts where people could be transitioning, where you might have the treatment as a time-dependent covariate over time in those situations. That creates a lot of complications that I'm not quite sure that I could answer how to address that at the moment. But as for some of the other staggered designs, I would think that it would be dependent on how the design is rolled out, and if there is going to be concurrent controls that are happening, or how we have to define some of those issues. But it is a complicated issue to deal with. Censoring creates such difficulty. I mean, we already know missing data is a problem, but when we're dealing with censoring in these situations, it creates other complications, especially when when there's dependence.
One of the points that you made was that you thought people should have at least 10 clusters. And I think you were referring to the total number, so that would be 5 per arm if we had 2 arms.
Yeah.
Yeah, over many years now, given my age, I have been arguing that people ought to have at minimum 8 to 12 per arm. So 5 per arm strikes me as a very small study. What's the basis for 5 as opposed to something more in the 8 to 12 range per arm?
Well, I'd like to tell you I would love to get people to have as many clusters as possible. But I think it's mostly related to this when are the models going to give us valid inference? And I mean, and I could, again, I would argue, I would agree with you. I try and convince people to have as many clusters as possible. And again, when you're working with investigators, trying to have them understand that the cluster is the sample size and not like, again, this was STRIDE was a fairly large cluster randomized trial, but 86 is still not that large of a sample size. Everybody looks at the 5,000 individuals, but really it's those cluster sizes that are driving it. And so I think being cognizant of the methodology and the inference when we're designing these studies is important. So I think, again, as large as we can get is the best, but understanding what the limitations of the methodology are important.
Yep. I'm in the context of this sort of conversation, I'm always reminded of the first really substantial trial of this kind that I worked on, which was the Minnesota Heart Health Program, where we had 6 communities, 3 in each arm, and measured, thousands and thousands and thousands in each community. So would have been far smarter to have had many more communities and measured far fewer people in each. Yeah, it's a continuing thing. A question related to adjustment for the number of clusters, the limited number. You noted that when the number of clusters is small, we often need to make some kind of an adjustment in the methods to avoid an inflated type 1 error rate. You mentioned specific packages. I suspect they were R packages, but you didn't mention specific papers, and I was curious if the methods that are being used in those packages are the same as the ones that are offered for continuous outcomes or dichotomous outcomes. I can rattle off examples of papers, but I didn't recognize the software.
Though I was trying to find, and I apologize where I am scrolling in the wrong direction, I think. So the Wong paper that I referenced, and this Cox BCV package, it does use a lot of the common methods, and it's like the MD, like I could see the abbreviation, so I'm going to apologize. And I have referenced the paper. And as I said, we're going to figure out how to make the slides, because I do have a fairly substantial, although not exhaustive, bibliography attached to these slides. But they considered 9, and some of those are common across the different varying methods, and allow that paper is a great reference paper for looking at it and the relation, and again, with the package, so that you can actually correct the variance using some of those methods. And apologies again that I cannot remember off the top of my head but they are, yes, they're the common kinds of types of small sample corrections that.
So it's Mankel and DeRuin.
Thank you.
Fay
Yes,
and
thank you.
Grabard.
Yes,
Okay.
correct. Thank you so much. Yes.
All right. Familiar friends.
Yes.
Another question from our audience. Your point on the design effect as the ratio of the variance taken into account the clustering to the variance ignoring the clustering is important. Do you think trial reports should include supplementary material presenting this alongside any information about cluster sizes, et cetera, to support sample size evaluation in future trials?
Yes, I think as much information as we can report. So that's one way, as I said, that we could potentially get at the impact of clustering in the absence of having a great way of reporting the ICC. But I mean, any information that we can provide, and again, I will say we're at fault of this too, that we didn't provide enough of it. It exists in methods papers, but not in like the New England Journal paper that somebody's going to go to help them design the next study. I think we need to be better at reporting as much information as possible on the impact of clustering, on how we could potentially design the next study and take that into account, and whether that is, again, even with some of the ICCs that I mentioned, like using the censoring indicator, that is not a great method, but that is at least more informative than nothing. So we know that it might be biased, but at least it gives us some information as opposed to no information on understanding what the impact of the clustering may be for future work.
Well, I want to thank you very much for this presentation, and I've enjoyed our Q&A discussion here. Thanks also to the participants who submitted interesting questions. Let me turn things back to Dr. Moyer to close out our session today.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. We will be posting a recording of today's webinar on the Mind the Gap website, prevention.nih.gov/mindthegap, in a few weeks. Thank you and have a great rest of your day.
Thank you.